Hello, folks. Welcome to the I-STARR webinar series. Let's get started. We'll probably have people continue to stream in, but we want to make sure that we take advantage of this full hour that we have your attention. So I see some familiar folks entering the room, but if this is your first webinar, I-STARR stands for Infrastructure for Studying Treatment and Addiction Recovery Residences, and the I-STARR project aims to develop infrastructure to advance recovery science on recovery housing, particularly recovery housing for persons treated with medications for opioid use disorder, or MOUD. Today, we'll be hearing from Niles Zashki, who will be discussing tobacco use in recovery housing, determinants, policies, and opportunities for cessation implementation. So if you've been to an I-STARR webinar before, you'll remember that the I-STARR project is supported by a grant from the National Institute on Drug Abuse and is one of a part of a larger group of projects helping to, and that's funded by the Helping to End Addiction Long Term, or the HEAL initiative. It's also one of other projects that comprise the Consortium on Addiction Recovery Science, or the COARS network. So before we dive in, just some quick housekeeping notes about the format of this webinar. So all audience members are currently muted. We encourage folks to use the Zoom chat function to introduce themselves, to connect with fellow audience members, and also to ask questions of our presenter. We do have an I-STARR project staff member monitoring the chat, and we'll unmute folks after we hear from our presenter, so that folks can then raise their virtual hands and participate in discussion at that point. So if you've noticed, we don't allow AI note takers into the webinar. But this webinar and each webinar in the webinar series is being recorded so that folks who are unable to attend today can still be able to learn from this webinar. In fact, all registrants will be emailed a recording of the webinar to listen to later. Finally, just a quick reminder that closed captioning of this webinar is available within Zoom, and you can find out or find it and start using it with buttons at the bottom of the screen. So actually, let's go to the next slide. And here's where I can tell you about the I-STARR team. So I'm Amy Miracle. I'm a research scientist in the Alcohol Research Group at the Public Health Institute. I co-lead the I-STARR project with Dr. Karim Masson, who's a professor of psychiatry in the School of Medicine at the University of California, San Francisco. The team also includes co-investigators Sarah Zemore, Dr. Lenny Jason, and biostatisticians Mina Subbaraman and Libo Lee. We also have a communication specialist, Diane Schmidt, and the team's project coordinator is Quinoja Capiteni. Let's go to the next slide. So the I-STARR project activities are guided by an amazing, underscore amazing 18-member advisory board comprised of a diverse group of leaders from across the country. So our advisory board members represent recovery and recovery housing leaders, treatment providers and payers, national policy advocates, as well as researchers and educators. We recently added a new member to our advisory board, Dr. David Best, who's stepping in to replace Doug Polson, who retired earlier this year. Let's go to the next slide. And now let me tell you about today's presenter, Dr. Niles Zashki. Niles Zashki is a postdoctoral research fellow at the Alcohol Research Group and the University of California, Berkeley. Their research focuses on tobacco use disparities, implementation science, and recovery support services for people with substance use disorders. Their current work examines smoking and vaping within recovery housing environments and explores how tobacco cessation interventions can be integrated in recovery housing systems of care. So Dr. Zashki is also engaged in research related to cancer prevention and early detection. So without further delay, let's turn the presentation over to Niles to get things started on the topic of tobacco use in recovery housing. Niles, it's all yours.
Thank you so much, Amy, Diane, and Quinoja, and the rest of the amazing I-STARR team for that introduction and for the I-STARR webinar series. It's so great to be here. And thanks to all those in attendance for tuning in. I hope this is informative and engaging for you. I know there's plenty of experts here and people who are newer to recovery science and even some citizen observers here. So really excited to see such a diverse, great group here today. So the title of this presentation also is the title of an associated paper, which is under review right now for publication, called I Have to Have Something, and I'll explain what that means later. And the subtitle is Resident and Staff Perspectives on Vaping and Smoking Within Recovery Homes for People with an Opioid Use Disorder. And again, my name is Dr. Niall Zoschke. My pronouns are they, them, theirs, and I'm at Alcohol Research Group and UC Berkeley. Quinoja, next slide, please. So let me first start off by saying, why does this research matter? Today, I'm going to be presenting on research that I conducted a year or two ago and have analyzed for you today. This research matters because tobacco use remains extraordinarily high among people with an opioid use disorder. So unfortunately, 3 out of 4 people in treatment for an opioid use disorder use cigarettes, and others vape as well. And many of them are both vaping and smoking. Unfortunately, again, tobacco-related disease is a major source of harm and even death among people with a substance use disorder. So there is evidence that demonstrates that half of people with a substance use disorder ultimately pass on from a tobacco-related disease. Here's another critical point that I want you to remain aware of as we continue this presentation. Continuing to use tobacco after recovering from a substance use disorder or another substance use disorder, there's evidence that demonstrates that it can confer a 25% increased risk for returning to use to the other substance use disorder that someone is in recovery from. So continuing to use tobacco can undermine long-term recovery, in other words. Even considering those shocking statistics, tobacco use is oftentimes not a major priority in addiction recovery settings. Next slide, please. So let me tell you why I'm interested in this, just to tell you about my position here and my research. So I'll start with the personal. I'm in long-term recovery from a substance use disorder, and I'm a former tobacco user. I smoked for 10 years. I did a lot of the research. I did a lot of the data collection, and I led the analysis for the presentation today. So I'm highly involved in this research topic as well. And I have years of experience working directly with people in recovery homes and people who help run recovery homes. I'm interested in, of course, helping people achieve their recovery goals and achieve their other goals alongside recovery, achieving optimal health for people who have stopped using substances. But I'm also interested in their lives, in their well-beings, in their social connections, and their quality of life. So the goal of this research, which I'm presenting today, is to simply understand tobacco use in recovery homes, but not really to advocate for a specific policy or to describe a specific intervention which could help people quit in recovery homes. Next slide, please. So let's talk about recovery homes. So many of you know, and some of you might not, that recovery homes are drug and alcohol-free communal living environments. These are places where people live together and either achieve sobriety or sustain their sobriety together. And they're designed to support people most of the time who are in early recovery. Maybe they've recently left a treatment facility, or they've come out of incarceration, or maybe they were living on their own, but decided to stop using drugs and alcohol and live communally to support their long-term sobriety. And these recovery homes are increasingly becoming very important, like a cornerstone of the recovery infrastructure. All that being said, tobacco cessation services are almost never integrated into recovery homes. In fact, there is no study that has ever been published that evaluates the success of a tobacco cessation intervention in a recovery home context. And very little is known about how tobacco is used or how it functions in recovery homes. Next slide, please. Why do recovery homes matter? Let's talk about that. So recovery homes are places where people in recovery stay beyond just a couple weeks, but they might stay for months or maybe even years. So compared to a treatment facility, people might stay in a treatment facility for weeks or a month or two at the most. and then they're moving on to another recovery support environment. There are strong peer influences in recovery homes. Many of them apply the social model of recovery, and I won't get too far into that, but suffice to say that this is a model which promotes people learning from one another and supporting each other as peers in their recovery journey. So there's this tremendous shared social environment in recovery homes. The recovery homes can have clinical services, and a lot of them have social support services, but many of them don't, and most of them do not have the level of clinical treatment that you would expect in a formal treatment center. So these are environments are less structured, and there's less supervision in recovery homes, but they still do have some structure and supervision. And what we're thinking, many of the researchers in this field are thinking that recovery homes are have a great potential for establishing other long-term health behavior change beyond just substance use recovery. Carry on. Thank you. So what do we know about tobacco use in recovery homes? So as I mentioned before, tobacco use is extraordinarily high in recovery settings, and 3 out of 4 people in opioid use disorder treatment smoke cigarettes. And people who live in recovery homes smoke and vape at substantially higher rates than the national average, and about 15% of Americans currently smoke, to put it in perspective there. And as I mentioned before, tobacco use may confer poor long-term recovery outcomes for people, and a lot of people end up getting a disease or even dying from tobacco use who have recovered from substance use disorder. So while cessation interventions are effective in all kinds of settings, um, they've never really been tested formally in recovery homes. And it's important for us to consider that evidence demonstrates that when people quit using tobacco, it does not jeopardize their other recovery goals. Carry on. All right, great. So let's talk about the recovery home environments. So beyond the use of tobacco among people who live in recovery homes, tobacco use treatment staff also use tobacco at higher rates than the national average. And this higher rate of tobacco use is associated with lower delivery of tobacco-related services in treatment environments. So staff who use tobacco, they're oftentimes uncertain or maybe even ambivalent about implementing tobacco cessation services in recovery settings. They just might not know how it's going to work, especially if they're using tobacco themselves. So the high rates of tobacco use in treatment settings can unintentionally reinforce tobacco use among people who are accepting services there. And it's important to consider that because these environments are highly social, tobacco use is socially shaped, and those relationships and organizational culture do influence tobacco use. Next slide, please. Okay, I'm looking for there we go. Okay, great. Thank you so much. All right. So we talked about what we do know about tobacco use in recovery settings. Let's talk about what's not known, and then we'll talk about the research and how we tried to fill some gaps here. So we really don't know why people in recovery homes continue to smoke or vape beyond that it is an addiction. We don't know how tobacco functions socially in recovery homes. We don't know how those peer relationships and social learning influence tobacco use in recovery homes. We don't know how staff view tobacco use and cessation, and we don't know how residents view tobacco use and cessation. And we don't know the appropriate timing or approach for tobacco cessation interventions in recovery homes. Carry on, please. So why was this research needed? Previously, all the research, well, not all of it, but a lot of it has been about, can a cessation intervention work in a treatment facility? And the answer is yes. There are cessation interventions that do work in substance use treatment facilities. But what we asked in this research is, what is just the role of tobacco use? What are the experiences of people who work and live in substance use recovery homes surrounding tobacco use? Why do people smoke and vape? How is tobacco used socially? And what do staff and residents think about using tobacco and quitting? So let me just tell you right off the bat, this is an exploratory study, and we did not purport to evaluate a specific intervention or policy surrounding tobacco use. So I will not make claims about what's best to come next. Next slide, please. What are the specific research questions for our research? How do residents describe their own tobacco use and the tobacco use of other people in recovery homes? What are the social functions? What is tobacco use doing for people living in homes? And how do staff and residents perceive that tobacco use and the idea of quitting? Next slide. Let's talk about the specific recovery home context for this study. So we analyzed the qualitative results or results from interviews with people who were living and working in 15 homes across the state of Texas. And these homes were specifically tailored for people with an opioid use disorder who were also taking a medication for their opioid use disorder. The homes did all have existing smoke-free indoor policies and vape-free indoor policies, but tobacco use was permitted outside. The houses were all staffed by a house manager and sometimes additional recovery support personnel. So if you're aware of the NAR levels, these were all NARR level 2 and level 3 homes, but that just basically means that these homes had some level of social or clinical support embedded into them. So shared just a little teaser about the results. Smoking and vaping was highly visible in the houses, based on site visits and based on the qualitative interviews that we conducted. And every home had a shared smoking or vaping space outside. Tobacco use was socially embedded into the routines of people in living in the homes and people working in the homes oftentimes too. And in our study population, almost 90% of people use some form of tobacco on a daily or weekly basis, which is a really shocking statistic. Carry on. So you may be familiar with this study. You might be thinking, oh, that sounds like Project Homes. That's because this was conducted within Project Homes, this multi-site evaluation study for opioid specific recovery homes among people who are taking opioid use medications for opioid use disorder. And so we interviewed 73 residents and 30 staff members for this research. Carry on, please. All right, so I'll just talk very briefly about methods. If you want to pick my brain about methods, we could do that in the Q&A or offline sometime. But we conducted these qualitative interviews where we sat down with people for 60 to 90 minutes. The interviews were semi-structured, and we asked them about their lives and about their recovery, but we also did ask them about their tobacco use. And again, we interviewed people who live and work in the homes. And then we conducted thematic analysis on the results, which composes the results which I'm presenting to you today. Carry on. All right, so I'm going to start big about the results and then we'll drill down deep. So this is a big picture here. Tobacco use was nearly ubiquitous in the recovery homes. As I said, almost 90% of people living in the homes were using some form of tobacco on a daily or weekly basis. And the folks who lived in the homes described that they had oftentimes used tobacco while in active substance use, also in treatment facilities, and then additionally, they're continuing to use tobacco use while living in recovery homes. And tobacco was just a normal everyday thing in these homes. One resident even said, yeah, I think we all use tobacco here. Carry on. Here's a big picture of the findings here. So what did we find that tobacco use was doing in recovery homes? So clearly people are dependent on using tobacco. They're dependent on nicotine. But tobacco was also described as assisting people with coping with the stress of living in a recovery home and in coping with substance use recovery. It was part of a ritual and a routine for people's daily lives. Tobacco provided folks a sense, this is what they reported, of autonomy and control of their lives to some degree. And there was a major social connection that happened with using tobacco with one another, the residents using tobacco with one another. And tobacco provided comfort for people who were in a very new and sometimes foreign environment, who have been through a lot. Next slide. So let's talk about this coping and dependence theme first. So participants described tobacco as providing a short-term relief for stress, but folks did mention that it has drawbacks. One participant said, it doesn't really fix any problem. It just fixes the problem that it created, meaning people have a craving for tobacco, and then using tobacco provides relief for that craving. But it did help people emotionally regulate and provide a familiar routine, something that they had depended on for a very long time throughout their lives. And it was a dependable source of comfort and something that's legal and something that's permitted in recovery home environments. So anybody can go buy a pack of cigarettes and enjoy them in their recovery home. Carry on, or I should say outside the recovery home. So here are some quotes that illustrate this theme. One resident said, cigarettes, that was our escape. Another individual said, when you get into an incident with a staff member, meaning some kind of dispute or disagreement, the first thing we usually do is go out there and smoke a cigarette to emotionally regulate or to de-stress. And one person, actually a number of people said, I have to have something. I just stopped using heroin, or I just came out of jail, or I've been living rough for a long time. And now I have a roof over my head. I have to have something. So that was a common refrain, and that composed the title of this presentation and the title of the associated publication. Carry on. All right, let's talk about the next theme, ritual and daily life. So tobacco use was embedded in the everyday routines of people living in recovery homes. So oftentimes people would wake up, early in the morning, getting ready for their day. They would take care of their personal hygiene, and then the first thing they'd do afterwards would go outside and vape or smoke a cigarette. Oftentimes after communal meals, thinking people have breakfast, sometimes lunch, and oftentimes dinner with one another. Afterwards, they're going out to share a smoke or vape with one another. And folks were gathering in the designated smoking spaces or tobacco use spaces. So each home had a gazebo or a front porch or a back patio where people were very commonly gathering to use tobacco. Pretty much at any given time, you might find someone out there, gabbing, sharing with another resident over tobacco use. Carry on. Okay, let's talk about tobacco as autonomy and comfort. So recovery was described by many residents and staff as very stressful and fragile, something that they wanted to protect, something they'd put a lot of work into and really needed to maintain. It was very overwhelming for a lot of people, thinking they may have changed their social and living environments multiple times in the past, few months. They might have gone to jail. They might have been living outside. They might have been in a treatment facility, an intensive inpatient treatment facility, and now they're in a home, which is totally different. A home of their own, where people have their own bedroom or their own bed, where they get to store their stuff. They have a roof over their head, meals. They're living with other individuals who they're forming relationships and bonding with. So now they've left a very overwhelming environment and they're coming into a new one that has its own new stressors and social dynamics. And oftentimes, their previous environments were highly structured. Think about how highly structured jail is and how highly structured a intensive inpatient treatment facility is. Recovery homes are structured, but they're not nearly as highly structured as those previous environments. So in recovery homes, tobacco provided that familiarity of, from their previous experiences, their whole life experiences, a kind of continuity for individuals. And it provided a sense of personal control. You know what? I have the blues, or I'm feeling excited, I want to celebrate, or I want to relax. I'm going to have a cigarette outside. And it provided sense with people with a sense of freedom. Carry on. So here's a couple quotes that illustrate this theme. One individual said, with tobacco, you don't feel like you're being stripped of everything. So thinking they stopped using opioids, they're not in jail anymore, they're not in an intensive treatment facility where their lives are under high levels of control. Now they have autonomy and some freedom living in recovery home. And with tobacco, they don't feel like they've been stripped down to the bone. Okay, so another quote that illustrates this is from a staff member. The staff member said, if you have a really strong policy, anti-smoking policy or smoke-free policy, it makes the residents feel like they're in jail again because they can't smoke. And that's a very negative experience for people, feeling like they're under control or they're under someone else's control. Okay, carry on. All right, so residents and staff oftentimes frame quitting as very important. People did not discount that quitting tobacco was critical. pretty much everybody said, yeah, I would like to do that. There wasn't a single person we talked to who said, no, I've never thought about it. But people oftentimes said, you know what, that's something for me in the future. And I have additional priorities right now that are taking more importance than quitting tobacco currently. So participants, staff, and residents prioritized readiness for quitting and appropriate timing for when someone should try to make a quit attempt. And importantly, self-direction in the process. So staff particularly said, you know what, we don't want to come down on people and we don't want to create an oppressive, smoking cessation regime in these homes. We want people to take the steps for quitting tobacco on their own terms, self-directed when they're ready for it. So generally speaking, they really avoided coercive approaches in these recovery homes for um, helping people or insisting people quit. Basically, no one insisted any resident of any home to quit. People commonly said this was a refrain, a familiar refrain in the qualitative results. We're focusing on one addiction at a time, meaning people are still focusing on their opioid use and recovering from that. And then someday, that's when we'll tackle tobacco use. And more, I wanted to mention, and this is even more shocking. One or two individuals that we talked to, residents, said, quitting tobacco is going to be harder than quitting using opioids. That's something we should really consider. Okay, carry on, please. All right. So the next theme is that tobacco served as a social connector for homes. So keep in mind that these homes, all of the homes in our study, followed a peer model for recovery, the social model for recovery. So these social dynamics are not only critical just for an individual, but they're actually part of the recipe of the and design of these homes. They're supposed to involve social learning. So tobacco functioned as an icebreaker for individuals. So a lot of times home will have five, six, seven, eight folks who are living there, and then someone moves out, and then a new person moves in. Well, when that new person moves in, they're the new person, and they're not ingratiated yet. So one of the first things that people do is share tobacco with the new individual who's living in the home to break the ice and to bond, to pass the time, to enjoy themselves, and to make those deep connections. So when we were observing the homes, the research assistants, including myself, we would spend time at the homes, and we would see people having deep conversations, important conversations, or just passing time with one another, bonding out on the back patio or in the smoking gazebo, sharing tobacco with one another. Keeping in mind that this social process is very important for the recipe for recovery in recovery homes. So these gathering spaces were places where informal support happened and those relationships were being built. Next slide, please. Here's some quotes that illustrate this theme. So if you've ever been to an AA meeting or if you're familiar with AA or NA, there's a coffee pot. Not only just a coffee pot, but a big urn. And people will gather around the urn before and after meetings. And so one of the participants, a staff member, said, you know what, using tobacco in the recovery home is like at AA when everyone's standing around or sitting around the coffee pot. And people said, we do a lot of hanging out, smoking, chatting, bonding outside on the patio or in the gazebo. So, beyond the individuals who are living in the recovery home using tobacco while they're bonding, we also found that sometimes staff share tobacco with the people who are living in the homes in these similar ways to build relationships and to break the ice. Next slide, please. So tobacco became part of caregiving culture in a recovery home. The residents were sharing tobacco with one another, giving each other cigarettes or buying cigarettes for folks who couldn't afford it from time to time. But this is where tobacco use among staff really became an important finding here. So we found that staff were using tobacco at high rates as well. And staff occasionally shared cigarettes with people living in the homes, smoked or vaped with people who were living in the homes, and used tobacco to build rapport. And one resident we quoted here said, after I moved in, I really didn't have much of anything. I really just had the clothes on my back and a few possessions. I didn't have any cigarettes. And that was stressful. And all of a sudden, there's a pack of cigarettes on my bed. And what he was implying was that a staff member had bought him a pack of cigarettes as kind of a welcome gift to join the home, and so that the transition for living there wouldn't be so stressful without tobacco use. Now, you might be thinking, this creates an important tension here because the people who are working in the homes want to make the environment comfortable and cozy and welcoming, and they want people to come as they are, especially everything they've been through, the residents have been through. But also, we might be worried here about unintended normalization of tobacco use in recovery homes, which we're going to get into here in a minute. Carry on. Okay, so we asked people about quitting. What do you think about quitting in a tobacco in a recovery setting? And people said, "Oh, sure, I've quit before and I've tried to quit." Now, when researchers like me think about quitting, when we ask about quitting, we're talking about stopping all tobacco use, all vaping, all dipping, no pouches, no cigarette smoking at all. But what we found was when people in recovery homes talk about quitting, actually, most of the time they were talking about switching products. So they said, oftentimes people would say, "Yeah, I did quit smoking," or "I did quit tobacco use." And then they would say, "Now I vape." So, and then sometimes people also switch to dipping as well. Oftentimes people were using both smoking and vaping, depending on what was available or what they felt like doing. And even more concerning here is that at least one participant said, "I never used to use tobacco before I got into recovery. But being in a treatment facility and being in a recovery residence, I actually started smoking tobacco in these contexts." So when folks talked about switching products or quitting, they did have specific motivations, which is very important for us to consider if we do want to someday compose a specific policy or cessation intervention for people in recovery homes. So people cited concerns surrounding health. One individual had a lung disease from tobacco use that he was really worried about that was causing a lot of medical problems and high medical costs. So people were worried about the costs of both purchasing tobacco and the medical concerns. People were worried about the smell of cigarettes. So they oftentimes switched to smokeless tobacco or, dipping or vaping because it wouldn't smell. Their clothes wouldn't stink, in their words. Also, vaping and dipping was more convenient because, there's no rule against dipping inside the house usually. And oftentimes, while vaping is not allowed indoors, it's very easy to get away with. So a lot of the times people did vape indoors. And people were worried about the social acceptability. These are folks who have been highly stigmatized surrounding their opioid use disorder or even oftentimes injection drug use. And so people were worried that smoking outside might confer some kind of negative stigma, or people might think about them in a negative way if they were viewed as being a smoker. Okay, carry on, please. All right, so here's some quotations that talk about managing risk and switching products. One individual said, "I quit smoking and now I just vape at the lowest nicotine level there is," meaning the lowest concentration of nicotine in their vape. And one person said, "I don't really know if this is any better than smoking." And another person said, "But with vaping, at least I won't stink like smoke." Carry on. All right. So to sum that up, quitting usually meant for folks switching to a different product that they preferred to mitigate or manage some type of drawback. And people were thinking about reducing their harms rather than quitting tobacco entirely. Now, importantly, people really didn't know what to make of vaping. They really didn't know if it was healthier or better, but sometimes people thought it was cheaper and at least it didn't smell bad. Carry on. Okay, so recovery homes are facing a very difficult balance here. The people who run the recovery homes really want to help residents feel at home and socially connected and stable and comforted and welcome. And a few of them said, if we have an all-out ban on the campus surrounding smoking, a lot of people just aren't going to move into the home. And they were worried that that would prevent people from working on an opioid use disorder unnecessarily. But on the other side of the coin here, we need to be concerned with normalizing or reinforcing nicotine dependence in recovery homes. and making quitting more difficult for individuals because of the permissive environments and the high rates of tobacco use in a recovery home. Carry on. Okay, so why does this matter for research? Why did we do this and what does this mean? So, our team and other people in the field think that recovery homes represent a really untapped setting for all kinds of health promotion activities. So, Dr. Miracle and team, talked about HIV and HIV prevention in recovery homes. So that's an example of a health service that we ought to consider implementing HIV prevention in recovery homes. But could tobacco cessation be an intervention, or could there be a policy that supports people quitting tobacco also introduced into recovery homes in the future? So there's some tremendous opportunities that recovery homes pose. One, already recovery homes have the peer support infrastructure and those existing relationships, those tight bonds with people who are living there. They offer continuity after a treatment facility. People just got out of a treatment facility and now they're living in a recovery home to continue their recovery journey. And these environments are oriented surrounding improving their lives and stopping using substances. But there are major unanswered questions remaining. So, one, what is the appropriate timing of introducing or encouraging someone to quit using tobacco? How do we know when someone's ready to do it? What are the roles of staff members in maybe implementing or supporting tobacco cessation? What are the best policies that are going to help recovery homes not unintentionally, kind of promote tobacco use, but also won't alienate residents or take away some of those social benefits that they're getting from sharing tobacco? And there are a lot of peer-led smoking cessation interventions. Are those appropriate for recovery homes because they share some of this peer learning context? Carry on. So here are the questions that I hope to answer someday with my team, and I hope some of the other researchers here think about. How and when do residents want support for quitting? What do they prefer? What's acceptable? What's going to be feasible? Which existing cessation interventions, if any, will fit recovery home environments? How can recovery home staff support residents who do want to quit and not alienate or, somehow confer drawbacks to the people who aren't ready to quit? Are there existing peer-led tobacco cessation programs that would fit right into recovery home culture? How does tobacco use change across the recovery journey? Understanding that almost all of what has been published in the empirical literature on tobacco cessation and recovery is in the context of in the context of substance use treatment facilities and not in recovery homes. And what are the best policies that we can institute for supporting people who do want to quit or to reduce people's use? Carry on. But there are important challenges for future work that we need to be very cognizant of. So, how do we support cessation without undermining the sense of autonomy and control that people get from tobacco use, without undermining those social connections and engagement in recovery? So, something for us to consider. We learned from this research, at least in our context, that a lot of important bonding and relationship building happened with tobacco use concurrently. Can our future cessation interventions account for that and come up with some replacement for those important bonding opportunities without just taking them all away and, having that drawback for people who are in early recovery? And importantly, staff ought to be involved, at least in the formulation of these new policies and potential interventions, but maybe staff should be involved in implementing them. But staff are also using tobacco at high rates. How do we support them? And how do we accommodate and account for their own tobacco use as they potentially implement these new policies and cessation interventions? Carry on. All right, so I want to disclose a couple limitations and be humble with our research approach. So all the findings that we presented today come from Project Homes and those 15 homes across the state of Texas. So while these results to our, best ability, do represent the authentic context and experiences of people living in our homes. Take that precaution when you apply these results to your own setting if your setting is different. So if you're researching or working in level one homes where there's no manager or social or medical service, a clinical service on site, think about how these results might change or how they might be adapted to your environment. Or if you're working in a treatment facility, similarly, think about how recovery homes in our context differed from your facility as you kind of transport our results to your practice or research. So importantly, all of the homes in Project Homes had a house manager on site who lived there and oftentimes additional structured social and clinical support. So if your environment doesn't match that, then these results might not match your environment too. And also keep in mind, this research proposed or purported to just characterize tobacco use and not to come up with a specific policy recommendation or a specific cessation intervention, although that's what I hope is next for me in my career with another grant. Carry on. So if you leave thinking just a few things, here's what I hope your takeaways are. One, tobacco use was deeply integrated into recovery home culture in our study. Two, residents were using tobacco to cope with their stresses from early recovery and from being in a new environment. People used it as a daily ritual and routine, and people bonded and connected using tobacco use concurrently. Staff said, you know what, we're really focused on the stability and autonomy among our residents, and we're not so focused on smoking cessation just yet. It's a matter of timing. Recovery homes, what we think, may pose an important but overlooked setting for future cessation interventions and policies that might support tobacco cessation. But importantly, much more research is needed to understand how recovery homes can support residents who do want to quit, who are ready to quit, without alienating people who aren't, and preserving that level of autonomy and connection and engagement in recovery, in their primary recovery goals. All right, last slide, please. Okay, I just wanted to thank you all so much for coming to this presentation. I hope you find it as important as I do. I hope you found it as stimulating and thought-provoking, and I hope it answered some important questions for you. And I'm ready to take your questions and answers. If you want to learn more about Project Homes, you can scan this QR code or just Google Project Homes. I see Steve Herrera, the office manager or the research manager for Project Homes, just gave me a clap. Thanks so much, Steve, for making it. And if you have further questions, you can email me at nzoshki@arg.org. Thanks, and I'll conclude there.
Fantastic presentation. Thank you so much, Niles. And thank you for providing your contact information for webinar participants. I'm suspecting that people will want to see your slides and have additional questions outside of the discussion. We have 10 minutes for discussion, folks. I know that the chat has been lighting up. Several people have questions, but at this point, feel free to unmute yourselves and raise your hands if you do have questions that you want to ask Niles during this context. Does anyone want to unmute themselves and ask a question? We also have several questions in the chat. I see, Albert, you have your hand up.
Yeah, and this is just a question and like to get your thoughts. Great presentation. Definitely important to really think about smoking and, possibly smoking cessation efforts in recovery homes or, similar programs. Do you think that there are efforts or do any models in terms of Texas exist that are providing smoking cessation services in this type of setting?
Thanks so much, Albert, for that great question. I can't answer that question because that study has never been conducted. So what I'm hoping to do is currently I'm helping write a grant application which could more accurately characterize the policies and existing services in a broader sample of recovery homes. So no one, to my knowledge, no one knows the answer to that question. But I can tell you from our study, there was no model that was applied and no model that was recommended that people said, oh, this is the best way to support cessation and in recovery residences. And I'll take the opportunity to answer a question in the chat that is very similar. So Roland Lamb asked, how were staff supportive of those who are ready to cease their tobacco use? The answer is the staff usually didn't. They didn't know what to do. They did not have formal recommendations. There were no policies. There was no literature that instructed them on how to do it. So sometimes I think they would refer them to like, oh, we might know a treatment facility or a program that does do this cessation. And they certainly supported it, but they did not have a playbook for how to do it, which is really important for us to pay attention to. Thank
So I see Lenny has his hand up, but Roland, you had several questions in the chat. Do you want to follow up with any of them?
Uh,
Yeah, I can
just,
answer.
just,
Yeah, okay, go ahead.
I'm sorry. Just wanted to ask, did you get a sense of what people came to the door believing? We found here in Pennsylvania, and I'm involved with the Pennsylvania statewide tobacco-free recovery initiative, and we found here that a large part of it is that it goes back to your point about normalization, goes back to what people believe and the information they walk through the door with. And you have staff that believe that, for instance, you can't, have somebody can't, while they're in treatment or while they're in their recovery or early stages of recovery, begin, to initiate uh, 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 tobacco cessation. And that's in actuality a false belief we found here in Pennsylvania. But I guess my question to you was, when you did your research, did you have a sense of what people came to the door believing about themselves and their tobacco use?
Great question, Roland. Thanks so much. So, yes, there were specific beliefs. And thanks for bringing up that myth. There is a myth that people in recovery really can't or shouldn't quit tobacco. But I will tell you, many of the participants in our study, the residents, said, you know what? I have tried to quit, or I would really like to do that. And I might be ready, or I think I am ready. Keeping in mind, when they're talking about quitting, oftentimes they're talking about switching a product. So that's a belief that's important for us to address. That researchers and cessation, professionals, when they're talking about quitting, they're saying you got to stop using all nicotine. But when people are living in the homes, they're thinking, oh, I need to stop smoking. Okay, so that's very important disconnect that we need to pay attention to. Additionally, the staff did have a belief that now is not the right time for most of our residents because their recovery is so fragile. But that is also a myth. Understanding that people who continue to use tobacco during and after recovery have there's evidence that demonstrates they have a greater risk of returning to substance use of their primary concern. So that's complicated, and we need to
Yes,
disentangle
it
that, and
is.
more research is needed about that.
Excellent. So Lenny, you were patiently, you had your hand up. Do you still have a question?
Sure. Thank you for the presentation. Excellent material and certainly an area that needs more work. Um, in the 1960s, almost half of men were smoking, and we can sort of now see the same issue in recovery homes where the majority are smoking. So you might learn something from the last 50 years. And one piece that might be worth thinking about for recovery home workers is what about the non-smokers? What are the rights of non-smokers? And maybe that's something that could also be considered. And one thing I thought of as a community psychologist, wouldn't it be cool if you could find houses where nobody was smoking? And basically, what would that mean for people's ability to kind of stay abstinent over time if they didn't have to deal with two addictions, they just had to deal with one? I don't know if there's many houses out there, but I bet you among the thousands that are existing in the US, there's probably several that are really smoke-free. Might be worth finding out.
Lenny, thank you so much. What a great thought and great idea for a new grant application. If you want to tag team it with me, doing a comparative analysis of smoke-free versus, tobacco permissive recovery homes, I agree. We need to pay attention to the past 50 years of progress and why this progress has not been, how people who have an opioid use disorder have not benefited from that progress. Okay, I want to take other questions if there's.
I think there's time. So there's a number of questions in the chat, but I want to get to Brian. Do you want to unmute yourself?
Yeah, thank you. Great presentation. Thank you so much. Quick side note, I am the COO of a recovery community organization in Virginia, and we provide recovery housing as one program that we have. And we've been trying now for 13 years to figure out the best smoking cessation, or right now we're running just a group that we kind of formulated, put together ourselves called Nicotine Recovery. The sad truth is, or I guess the kind of both sides of the coin, we have a lot more success with harm reduction. So getting people to maybe slow down on how many cigarettes they're smoking a day, how much they're vaping. I can probably count on two hands how many people we've had, and we have a relatively large program that have come through and quit smoking or vaping in our program. Some maybe afterwards, but in our program while attending the classes that are, you know, we don't say anything's required here, but but if they're part of the program is what we say. And so it's really it's tough. It's a really tough environment. I will say that. The my question was, or maybe my observation is, or in your study, did it ever come up? Did you ever ask the participants if they were getting any motivation or any incentivizing or anything from their behavioral health care providers or just their healthcare providers? Because that's one thing I can know, like I know anecdotally from my own story. So I'm a person in recovery from opioid use disorder, bipolar disorder, and now nicotine. Recently quit nicotine. Nicotine was the hardest thing I quit. And which is crazy to say. But I just don't, I never got any of that from any kind of help from my healthcare providers, any kind of like, and so it's just interesting to look at it. Okay, like, yeah, recovery housing has a unique opportunity, but are we just failing people in recovery, period? And I think that's a lot of what we hear from our participants as well. So just wondering if that ever came up in your research.
Brian, great. Thank you so much, and congratulations to you for quitting and being in long-term recovery. My heart goes out to you. So a couple of things that you mentioned. One, you talked about harm reduction. So I really want to make a point about this because in the tobacco cessation field, there really is not there's not a widely endorsed concept of harm reduction. It's a major disconnect between this and the substance use recovery field, where in substance use recovery, people are thinking, how can we manage the downsides of people's substance use? But in smoking cessation or tobacco cessation, people really are thinking it's a zero-sum game, particularly because continuing to maintain a dependency on nicotine is very likely to return people to smoking. And additionally, there's no clear evidence that demonstrates that vaping is healthier for tobacco use. So there's really no safe level of tobacco use, and people are highly concerned with ever saying anything about like, oh, well, this would be healthier for you, or this might be a better alternative. Now, consider the residents who said, well, it's cheaper for me, and I don't smell bad, and I'm not one of the stigmatized smokers outside. Well, that's meaningful to people. So even those gains are something that we need to pay attention to. Now, I don't know if that's harm reduction or not, but we ought to be paying attention to people who are, in recovery, who are quitting tobacco. Your second question was about behavioral health services already available. That did not come up. So importantly, people are accessing all kinds of healthcare opportunities. Specifically, almost all the people in our study were accessing medications for opioid use disorder, probably not paying for it out of pocket. So there seems to be a big gap in conscientiousness surrounding, well, hey, your doctor actually could provide you take-home medication for smoking cessation, nicotine replacement therapy. And almost all the homes had on-site storage for medications for opioid use disorder, but not a single home mentioned that they also had nicotine replacement pharmaceuticals on staff. Now, they may have and didn't mention it, but I strongly believe that none of them had that available. So major opportunities. Great question, Brian.
So, guys, I'm so sad that we have to break off discussion, but we do. So, there were questions in the chat. Carlos had a couple questions in the chat. Freed Whitman has a question. I would encourage folks to reach out to Niles and send your questions directly to him because we won't have time to address them. This has been just an amazing presentation and an even better discussion. But before we leave today, I do want to give you a heads up about some things that are coming up in the next couple months with I-STARR. And again, please reach out to Niles directly with your questions if we didn't get to them. In terms of what's coming up with I-STARR, next month we'll have another webinar, same time. We'll feature Dr. Meena Sumaraman, one of our I-STARR team members, who will be presenting on cannabis use among sober living house residents. In August, we'll start a new series of webinars that will run through December. Now, we're still in the process of scheduling these webinars, but some of the topics we'll be addressing in this next installment include peer respite housing, overdose vulnerability among individuals experiencing homelessness, and findings from one of our pilot study directors, Dr. Justin Bell, who examined low barrier recovery housing. We'll definitely let you know when these webinars are on the website so you can register for them. But unless otherwise noted, I-STARR webinars are held on the third Tuesday of the month from 11 to 12 for folks on the West Coast, which is from 2 to 3 for folks on the East Coast. You can also stay in touch with us through various social media platforms, which we've listed on this slide. So if you go to the I-STARR website, you'll also see information about the I-STARR training series. So the I-STARR training series consists of 12 webinars with separate training tracks for recovery housing operators or providers, as well as those who are interested in conducting recovery housing research. Folks who participate in all 12 webinars in the training series will receive a certificate of completion and be provided with the opportunity to be identified on the I-STARR website as someone who has completed this training. Now, at this point, since all the training series, the live component of the training series has ended, we can only track completion of the webinars if you register for the series and view the webinars on the I-STARR Learning Management System. But that's also on the I-STARR website. If you have any questions about the training series or about how to complete it, please feel free to reach out to us. We can get you started. It's really easy, really quick for us. But if you've started and haven't yet gone through all 12 of the webinars, no worries. Maybe sometime this summer you can find some time to catch up. A number of leaders in the field contributed to this training series, and we're really hoping that people will be able to take advantage of this free training that's available. So let's go to the next slide. While we're talking about upcoming events, I want to talk briefly about the National Conference on Addiction Recovery Science, or NCARS. You may recall from the top of the webinar, I-STARR is part of the Consortium of Addiction Recovery Science, the COARS network. COARS sponsors the annual NCARS conference, and this conference brings together researchers from all stages in training to stimulate an exchange of ideas and presentation of cutting-edge research, recovery science research across the spectrum of alcohol and drug disorders and their affected populations. This is a virtual conference, and it's being held September 23rd and 24th. Registration fees for this conference are reasonable, and early bird and student discounts are available. However, early bird discounts will end on July 24th, so better to get registered sooner rather than later, but definitely within the next month. So let's go to the next slide. I think this is our wrap-up slide. We do have a hard stop at the top of the hour, but I just want to again thank our presenter, Dr. Niles Oshki, for just an amazing webinar, but also everyone for their attendance, their time, and their attention. We hope to see everyone back here again on Tuesday, July 21st. But for now, enjoy the rest of the day. Thank you so much.
Thank you. Bye-bye.